just a minute.
So we're gonna, basically this is a town hall, so anybody can just say and have questions for all of us to learn. I just thought to give you a little bit of the summary of what the phase 1 was and what the phase 2 is. So certainly in phase 1, they were only doing emergency procedures and then just prioritize elective procedures. So if someone really needed it, then they will do it. So they screen for the COVID-19 patient, COVID-19 screening, and that continues to be done in phase 2 too. And then there were only the patients who could be in the offices, then no companions, except for what we learned here from Dr. Manuel. He's an OBGYN, and they were allowed a companion there. And face masks weren't at all time. So next slide.
There's a little bit of a lag here.
Okay, so for phase 2, now you can basically perform all of them. Each hospitals usually have, or each offices, whether you do them, they can create their own way that they want to decide which one goes first and which one goes last. I have heard that from groups of doctors that they get together, and then from all surgeons, they get together and then decide which one is going to go first and who's not, to get some orthos, they all get together and then decide who's going to do it. So each of them are doing it in a different ways, but we still have to have an adequate PPE. Hopefully by this time, everybody has, all the hospitals and all the places where you do surgeries and procedures, they all have it, and including the offices too. And the patients, they continue to be screened for COVID-19 before the procedures, and they are now allowed to have companions in certain areas, of course, if no symptoms. And again, face masks should be worn at all times. The companions, we were discussing it just before, and what they say is limit visitors to the facility to only those essential for the patient's well-being and care. And visitors should be restricted to the patient's room or other designated facility areas. And then they should be wearing face masks. So I'll pass the baton to Dr. Emmanuel, and so he can give us a little bit of what they do in there at a Kaiser as a, not in private practice or private place, but as a group practice.
Hello, everyone. Hope you had a good and productive day. I'll start with phase 1 and discuss our transition. In phase 1, it's a little different, make a little correction to what Dr. Pineda said. We would only allow the father of the baby or a companion in the back if they were essential in helping the patient. I think as of June 22nd, there has been some consideration. It's not across the board that we allow the companions in the back, but if they are essential to the patient's well-being, we have allowed that. But I'll say this, all staff, all employee, physician, staff are screened when we enter any Kaiser facility. That's also with not just a temperature, but a questionnaire. We must, in front of the screener, add disinfectant to our hands. There's no, well, good hygiene, I should say. There's no sink that's present. And then they allow only 2 personnel to the elevator, to enter the elevator. So I can tell you in the morning or at lunchtime or after lunch, it's pretty crowded. But they do maintain the 6 feet, the social distancing. What has changed currently is the type of surgeries that we're doing. So in the past, it was only those necessary. For example, we need to diagnose cancer. Currently, we are now moving into those that are in the queue and based on diagnosis as well as timing, how long they've been waiting for surgery. And that just recently began. We have not opened up our surgical facility in the District of Columbia. We're primarily doing all of our cases in Maryland and Virginia. I could say Washington Hospital System as well as Holy Cross would allow one visitor for the pregnant patient in labor, but there was no visitor for the surgical patient. And I haven't been in the hospital this week. I'm suspecting that has been changed in the district, but I can't confirm it until tomorrow. So that's my my experience with Kaiser Permanente as a employee or physician with the group. Any questions about my experience?
I think you can unmute yourself, or you have to unmute them.
What are you finding the response is? I'm just curious from the mothers, you know, delivering. What has this been like for you guys in terms of dealing with people delivering and not having the support they're used to having?
You know, Alice, I'll really say that because there was, let's say, a scare, public health commission that only essential family members or care be given to the patient, there wasn't much pushback. I can say though, since we've moved into phase 2, there've been tremendous questions from the mothers about fathers as well as family members attending. Because if you read online, it says all visitors, and some are interpreting that as whether they individually, if I have 1, 2, or 3 visitors versus instead of seeing all visitors to the hospital. So I will suspect as we progress in the phases, there will be more questions, demands, pushback from the patient as it pertains to their family members accompanying them during labor and delivery.
Any other questions, concerns with the phase 2? Or do anyone want to share what they're doing so that we can all learn? In our building, well, I'll say then in our building, they didn't close anything, not even on phase 1. You know, everybody, the doors were completely open. They didn't put restrictions in the elevators. They did put a lot of signs about, you know, where to, and this is a medical building, but they didn't really put any restrictions. If you suspected to have a patient with COVID-19 in the room, they will come and clean it completely, like a deep cleaning, and they will come with a, someone will come and disinfect the room, and they have done that with few places in the building. But other than that, it has been pretty open. Everybody has to wear a mask, but I've seen people, even the ones that work here, not wearing a mask, which is pretty, I don't like it at all. So I keep saying, you know, in the elevator, do you mind putting your mask on? And, you know, you forgot your mask, or where's your mask? But I have seen it daily not wearing the mask. So there's no, in our building, there's no one downstairs really policing, you know, who comes in and who comes out, which is a concern, of course. For the office, we don't have a sign outside that says you have to wear a mask, and if you are sick, don't come in. If you have any symptoms of COVID, I mean, we'll detail them, and we tell them not to come in, and then we check the temperature, and we give them a questionnaire for them to fill out. And then we do the same also for the employees in the morning. So just to be sure that they don't have a temperature, which we don't know exactly how much that good it is, but hopefully if you get one, maybe you save some other people from getting it. So So that's, and then throughout the day, they kind of self-monitor themselves, you know, for the temperature, and instead of having some person, they say, the guidelines said that you can self-monitor yourself. So we allow them to do that during the day. And if they feel sick for anything, they cannot come into the office at all. So the building itself has been a little liberal for a little liberal that I would like to see it. But in the office itself, we are very strict, and we don't allow anyone that is sick to come in at all. So I don't see any patient with COVID, or I don't get any, I am doing actually some testing. I do the IgG, I send them out, and I do the swab, but only for people that they are not sick. And I know that they have been in the office, they have been at home all the time. So there's some of them that are like, well, I want to visit my grandparents, and I want to know if I have it or not. So some of this, they have trouble. Now it's free. Now they have more places that they can go. But at some point, they have some issues that they could not get tested because they didn't have any symptoms. And they really wanted to see the parents. They are elderly in another state, and that's the most common question I have. So I am doing that for those people that I know that they really don't have it. Or well, 100% I cannot say it, but you know that the likelihood of having it is very low. So so I'm doing, and I dress myself from head to toe. It's very funny.
Yeah. Do you wear a N95, Dr. Pineda, when screening?
I don't wear N95. No, I would have a KN95, which is not a real N95. I cannot get an N95. So that plus my visor, and then a plastic cover all over. So
I can say that's what's changed recently. We always had an N95. We were fitted, but since June 22nd, we're required to wear the shield during any procedure that may arise, where patients are either coughing, sneezing. If we have to test for COVID in the office, we're required now to wear the shield, which I said prior to June 22nd, we weren't required.
Yeah. No, I did a few last week, and I'm just saying it because, again, for those, but now it's more open. Now they can go anywhere, even if they don't have symptoms, they can go and get tested. So I know Sibley is doing it, and the fire stations are doing it. And if you go to DC Health, they have a list of places, all the fire stations that they can go and get tested. And they also have, there's some pharmacies that also doing the test. So it's more liberal. So I didn't do anything this week. I just did like 2 last week. But and again, I don't have anyone that is coughing or sneezing or have any symptoms of that. Any other comments? Dr. Fuse, you were telling us about how your building is closed completely.
Yeah, no, I have a couple of comments first about a couple of things you said, Desiree. So one was about, what are you wearing when you're doing the COVID, when you're seeing patients in general? Because I think, I think the surge, well, just like you, we can't get real N95s that are in the small size. Mm-hmm. I would just like to be able, I know it's not, in the guidelines saying you have to, but I would really like to be wearing an N95 if I'm doing a physical exam, just because of the proximity. And I'd really like, I'd like to have one that fits. And so, I hear what you're saying. You're not wearing one because you can't get them. So we as well are not. I'm losing my train of thought in terms of the things you said, but you said a lot of things are really interesting that are different than what we're doing. So I would just say what we're doing. So our building is not a medical only building. So there were some other businesses in our building, and so early on our building was locked. And so we started to have to send someone down to meet our patients. And we finally got through to them to find out what their plan was for phase 2. And the plan is through phase 2 to stay locked. So what that means for us is every patient that comes needs to call the office. They need to stand in front of the building, call the number, which is, posted on the front window, and then say, I'm here. And then we send someone down to meet them. They do the temperature, they do the questionnaire, they bring them up to the office. But we're not seeing that many patients in person at this point. We're doing a lot of lab visits. So what I've been doing is having people come in for a really quick visit to get labs done. And then I'm doing a televisit with them. And like I said earlier, if they, and then I have a conversation. So I say, okay, we've done your labs, if it's physical, we've done the whole counseling bit. And now you have the option to schedule a follow-up visit just to do the exam. And then I say to them, okay, when you come for your exam, you're gonna literally be greeted, you're gonna come to an exam room, you're gonna put a gown on, I'm gonna do your exam, and you're out the door. We will have already done the billing, and there's just a quick visit. And I'm trying to really be short in those visits to limit the time, because at least based on what the CDC's guidelines say, contact tracing is for people that you spend more than 15 minutes with. So I'm hoping that if I spend 15 minutes or less in the room with my regular mask on, that I'm not passing a lot of COVID around from patient to me to patient. So, and what we're having to do, just because of our small space and we do not have multiple extra exam rooms, is we've all agreed as a group of doctors, there are 4 of us in the group, that we will put a space in between our in-person visits. So we sort of by necessity need to have some televisits in the middle. So I have created a schedule where I see a physical, and then there's a televisit, and then a physical and a televisit, and then an office visit, because we need the time to clean the rooms, because my staff are going batty, crazy, cleaning. So a lot of the talk we've had in the office is about how do you contain what the patient touches? How do we make sure, so that we don't have to clean every single surface? But my staff are still doing it. After the patient leaves, they're wiping down the table, they're wiping down this, wiping down. I mean, that takes time. So we can't possibly run patients back to back to back. And I assume that's the way we're going to have to do it until we have the vaccine, which hopefully happens. But I don't want to monopolize. Those are the basics of what's going on with us.
Yeah. Does anyone else has any, Dr. Agarwal, Dr. Patel, that is, she's there. Hey, how you doing?
Hi. So I'm really limiting any patients coming in the office if I can help it. We're really trying to do mostly telemedicine or e-visits or televisits. And in terms of, we have been doing COVID testing, but we're doing drive-bys. They're coming and they're doing basically observed self-directed COVID testing. So we're barely coming into communication with them, and we're having them put it in the Dropbox.
Oh.
That's a good idea.
Oh, okay.
Mm-hmm.
Auntie, are they doing the actual nasopharyngeal where they've got to get it all the way up in there, or are they just doing the nostril one?
No, so we had to do the nasopharyngeal one. They can't do that, but that's when we sent patients to Sibley. But LabCorp now, we have the nasal. It's actually an anterior nasal. It's not even a middle turbinate, so it's very easy. And then we will have the Quidel EUA Quidel quick test that's within 15 minutes. So that's also a nasal. So they can definitely do it. It's easy.
Do you have that machine in your office that does the quick one? Is that the Abbott test?
No, it's the Quidel. It's the only one that's FDA EUA. The Quidel that was, I think it was approved maybe a month ago, but they're just starting to send the equipment and test kits. So we've just been waiting. I think they sent it to the hospitals first. So we're going to be doing that, but we're still going to be doing drive-bys, but then we're going to have to bring it into the office, but we're still going to have them just get it and then leave. And we're just going to call them or communicate with them in some fashion with the results 15 minutes, 20 minutes later.
So is that a test that requires you to have some equipment, or you just need to have like test kits? Like the Abbott test, you had to actually have a machine. I don't know about this stuff.
So there is a machine, but it's CLIA waived, and there's a kit. It's basically just like you do a strep or a flu test in the office, but instead of eyeballing it, it's actually uses fluorescence. So you have to put it in the machine, and it's actually much more accurate in terms of reading. It also does strep and flu. So we thought it was worth doing it because we kept getting false negatives for strep. So I think this might be a more accurate test for that. Come, and also for the flu, which we're going to have an issue with flu and COVID. Alice, I can send you that information if anybody wants it, because I think that they want primary care physicians to order it. They're trying to really, the NBA and other people have requested it, and Quidel really wants to give it to healthcare workers, because you're seeing all the sports teams and these other companies or industries are wanting it. So we really need to get it for our healthcare offices.
Yeah, that's a good idea. Do you know more or less the pricing?
I know the exact pricing because I just spent a lot of money. The machine, there's no cost.
Okay.
You have to sign a contract. So we signed a 3-year contract, but we, as a primary care office, we know we're going to be able to use it in the next 3 years because we'll just use flu and strep. So I think it's, the office needs to, that specific entity needs to see if it's worth it. But so the machine, there's no cost, it's the kits that cost. So that's how they're making their money, really, is with the kits. So for one test kit, it's $23 per kit. So that just gives you an idea. Then, we have to add our time and administrative work, and we have to report every single one to the public health department, be it negative or positive. And I'll just mention to everyone, supposedly in the next 8 weeks, they're trying to get the antibody test as a quick test for EUA. So that's just another benefit, hopefully, that we'll see coming down the pike with this machine.
And it's 23 and it has the 3 tests together, or 23 just for the COVID test?
Just everything separate. And we did buy some flu and strep, and I don't know the exact price, but that's it's less than the COVID test kit.
Okay. And then you bill for the COVID test for yourself for
Correct.
Mm-hmm.
And with the CARES Act, we can bill, like, the insurance has to cover up to $100. As far as I know, although the AMA hasn't come up with new CPT codes for in-house tests, so I think that's maybe coming. But right now, the assumption is it's reimbursed $100, up to $100, depending on what you bill.
Mm-hmm. Well, that's good. So if it's 23 and then you get a test for 100, that's pretty good.
Mm-hmm.
Yeah, we should definitely look into that, because we're especially planning right now. Maybe isn't so necessary. We get into the fall and we have strep and flu. We were already planning to do drive-through strep and flu. We just weren't going to do the COVID, and we were trying to figure out how do we manage that. Like, well, we make sure you don't have these 2 things, but then maybe you have the other, and we send them somewhere else to do that test, because we haven't been doing COVID testing.
Mm-hmm.
Dr. Agwal, did you say that the patient, I went to their website, you're saying the patient can test themselves nasally and drop the test off?
Okay, that's our internal system, is that we would have them drive by our office, and we actually have a circle. It's a perfect area that they can pull in, and they're not blocking traffic, and it's private. So they would just park, and that's where our Quest and LabCorp boxes are too. So if we ended up using LabCorp or Quest, but we can just have them swab it in their car. We're just going to have them show their driver's license. We're going to have everything set up before they come, and all they're going to do is swab it. It's going to take them 30 seconds, and they're going to drop it in the well, if we're doing our own Quidel, we're going to have to take that and take it back upstairs and test it. But if we use Quest or LabCorp, that's what we're we're going to just have them put it directly in the drop box. But then we still have to wear PPE, but we don't have to be gowned necessarily. We would still wear our N95 and our face shield and gloves, but we're not actually going to be exposed to anything. It's already going to be sealed up when we get it. The other thing I would mention for anybody that's using Quest, that as of a week or two ago, they actually have mail, self-directed mail tests. So it can be mailed directly to the patient, and the patient can put it in the mail to Quest. And it's with FedEx. When I say mail, FedEx. And so that's another possibility for us to utilize. Now, we've been trying to get at least just one kit to test it out. And especially if you have a patient that's that doesn't want to leave their house except maybe to drop the FedEx or somebody else can, that's an option too. And that's covered, I think that's covered by insurance as well. Yeah. So Quest is something, and I know that LabCorp has one too, but I think that is self-pay, whereas the Quest is not a self-pay situation. I don't know how Kaiser, what they're using for their labs or internal labs.
So as a comment of that, the lab cord is the same one that you do for the nose. It's the same one that the patient will do by themselves at home. So it's the same test that, and the same, I use both lab cord or Quest, depending on what insurance, what insurance they have. And it gets paid by insurance. So, but LabCorp is the one that uses it, that bills. And as far as I know, what they say is that they're not allowed to bill more than 100 because that's what they're not allowed to make money out of it because of the situation that is a public emergency. So it's just up to $100.
So the one exception that I saw is Vault, that's has an FDA EUA approval, is a direct consumer marketed one that's a saliva test, which is not so accurate when you look at the data. But they're charging $150 because they're counting their mailing back and forth.
Yeah, probably. That might be, but to the test itself, I think they're just up to 100.
Yes.
Yes, I had another idea. So it's the only thing is about patients. It's good that you see them doing it because one of the problems with the one that they do them at home or they mail it is are they doing it correctly or not, or it's just like the anterior part is as good as going all the way in and getting the sample all the way up there. So for some reason we do the one all the way to the back because it's more accurate than the one just doing in the nares. So it may not be as accurate, but it may be just that they don't do it correctly or they don't get enough specimen. So when the patients do it themselves, yeah. But it's good to know what other people doing. I don't know if Dr. Patel has anything to say or ask. We're a very small group, so we can all chat. I guess, I'm not sure she's mute or not. Look like.
I think she said didn't she say she was driving? She may not be able to.
Maybe she's the one, yeah. So the other question that a lot of people is like, how long are they gonna pay for telemedicine? So that's a good point. We still don't know exact date or how long it's going to be like the public health emergency going on. We have some dates of the 15th of July and another say 25th of July. Pia she was just commenting that she was on the Board of Medicine meeting today. So can you share with us what you heard?
I'll unmute myself. Yes, we did ask the Board of Medicine about extending whether some of the measures that were put into place would be extended beyond, because they've been so successful, be extended. And the Board of Medicine that said that unfortunately any waivers or exemptions that were put in place because of the public health emergency would expire once the public health emergency is over. They are now, the Board of Medicine is considering regulatory and normal legislative routes to try and utilize some of the try to incorporate some of these practices on a longer term basis, but there's nothing permanent about that yet. They are also exploring opportunities to possibly to expand telemedicine, but that's in the longer, more time-consuming regulatory process.
We have also talked to some of the insurance companies. You know, Blue Cross Blue Shield, and we're going to be talking to Cigna soon and see for the impression, because it's nothing like a written. They do say that they think it's going to stay. Telemedicine is going to stay because not because we want it, but because the patient is going to want to have it. Not because it makes it, but it's just, you know, and it's true. It's just easier for them just to stay in the office or stay at home and have a conversation with us and visit with us about labs and things like that. So, so I think it's going to stay. The question that we are going to really fight in MSDC is to be sure that we can continue to get paid at the same rate, because then it will not be successful at all, because we're not going to be spending time in with the patient and them being, you know, then we're going to tell them just come in the office.
Correct.
So I think they have to really continue to be paying and that's one of the waivers that we're talking about right now. They're paying the same rate, but are they going to do the same before? So, but we will continue to push and, you know, for the same pay. So that will be something we'll continue doing. Is there anything else that it bothers you, that is that you have some concerns that the city or DC Health have managed? Anything that that you're worried about that you would like us to address?
I think it's just a general worry about flu season. I only heard this secondhand, but a patient called our office yesterday and told us that CVS is not going to be doing flu shots this year. And that may have been a particular CVS, but you know, with our practice, we have some people that come to our office and get them, but we have a lot of people that get them at the drugstore. And if the drugstore isn't doing it, and in our case, we're only seeing patients for labs with an appointment, which would mean for flu shot, the same thing. We'd require them to have an appointment. It's going to be a strain to get people in and out to do flu shots, you know, the way we usually are, the way we're currently doing them.
Well,
we have done something different this year. Just to share, we ended up sending out an email to our patients and asking them to pre-order their flu shots this year and prepay for it through our website. We don't participate with insurance, so certain regulatory stuff doesn't apply to us, but that I think has been really successful in terms of collecting money now to pay for the bill to buy the shots.
yeah.
But logistically, it adds layers that weren't there before, you know, because you've collected the money and then you have to then submit it once they actually get the shot and other things like that. But it certainly did raise awareness with our patients about the fact that when we give flu shots out, we have to buy them in July and we have to commit to them in July. And, you know, we basically wanted patients to give us a heads up whether they thought they were going to be able to get their shot like they usually do with their employer or, you know, somewhere else, when we thought people would be hesitant to go to the drugstore to get their shot. They don't want to wait in line there. And then again, I hadn't heard that drugstores might not be doing the shots, but if they aren't doing them, that's going to be an access issue. Hopefully
Yeah.
that one CVS is not doing them. I know there's some Walgreens that aren't doing Shingrix vaccines right now, for sure.
Yeah.
So,
Yeah, I have heard the same thing about not doing the vaccinations currently. It will be hard for them. I mean, that's a lot of money for CVS and for any of them not to do it. Because it's even harder to compete. Sometimes I get just a small amount because I used to get huge amounts, but then I stay with them there. Because everybody goes to CVS and it's simpler. They get the insurance, they take the insurance and everything. So I just sent them, actually. I just ended up last year. I just said I'm not going to buy them. I'm just going to send them to the stores or wherever they can get it, because they buy it in bigger bulks and it's cheaper for what they pay for it. So yeah.
Do you think that it may relate to we're limiting preventative care, although that we can get into a whole different questions about that, but maybe because they are now, the pharmacists can do COVID testing, not just the pharmacies that have partnered with, say, Quest or LabCorp, but maybe that will change. But I think, Alice, you're right, that they've already had to pre-order the flu shots. They know if they're going to be doing it or not as well. So that's actually really concerning if they're not, because I'd say at least half of my patients get it at the pharmacy.
Mm-hmm. Mm-hmm. Yeah, I do agree. I doubt that it's difficult to understand if they're not going to do it, because that is a big problem, and they get a lot of money from it. So I will say as a business decision, I don't think it's a good one. But they may be concerned about people sick and coming in, but they're starting to give some of my patients said some of the Shingrix vaccines and some of the pneumococcal vaccines. They did say, the pharmacist told them, just come back in 2 weeks that we're going to start doing it. So I think they were waiting to have like this phase 2 to then start giving the vaccines. So we'll see with the with the flu vaccine. Yeah. Any other issues?
certainly my plan of doing a visit and then a televisit is going to really backfire if insurance doesn't pay for the televisits come 2 months from now. I mean, again, if that's the case, we'll just have to bring people in and we'll do less cleaning in between. That's basically what happens. So patients will lose out, I think.
Yeah, I'm doing something like you do, like some telemedicine and some, in between. But it's it does require a lot of like, oh God, the telemedicine is coming. This is coming. So you are like, I'm wondering where can I go now? But yeah, I guess you get used to it. But it's I think at this point I was telling Alice before that I'm seeing probably 60% in-house, just in the office, and then the 40% in telemedicine. But they're long days, which I don't enjoy.
Yeah. We find currently what we're doing, we're not back to full capacity. So if we have, for example, our Capitol Hill office holds 10 physicians, only 5 could be in the office due to social distancing. So we have the other 5 performing telemedicine, and that's a tough day. The patients demand their full 20 minutes during that telephone or video visit. Mm-hmm. And what we've learned is we cannot have the physician on telemedicine for more than 2 days. The max is 3 straight because it's overwhelming. We have to give them breaks and bring them into the office. So it's a rotation. We initially thought, and we had physicians who were very excited and wanted the telemedicine, but once they realized that it was a very demanding day, they've asked to go back into the rotation. So that's our experience with that.
That's so interesting. I think I feel that way too. I think it is. I mean, it's just like now you're like, where should you be looking? Like the strain, lots of people are talking about that, the strain of the visits being hard. I find absolutely, my patient is there at 9 o'clock. Like if it's a 9 o'clock visit, I don't know if you see that, you guys, like they're there and they're ready to go. And absolutely, they're like, some of them are watching the clock. They're like, oh, Dr. Fuse, I've got 3 more minutes. I got 3 more minutes. Like as though there isn't like something that happens in between usually, right? Like usually I'd be walking in at like 9:05, 9:10. I would have put their chair to be ready. And by 9:25, I'm out the door. Like you're totally right. I haven't heard anyone else actually say that, but it's so true.
Yep.
What I'm finding I do differently is because, I mean, I do half-hour visits for office visits, right? So it's like a lot of time if all you're doing is talking for most patients, you know? But I find that what I'm doing now is I'm forcing the patient to sit there while I do things I usually do in between. So when they say, oh, I need a refill, I go, okay, let me take care of that now. Like I'm like that, you know, when you like call and they go, like something's happening, I do that with them. And I say to them, oh, let me write that down. And I write it, you know, like, and I actually schedule their follow-up visit during their visit, because what we were finding in televisits was I would say, okay, call the office back and make an appointment to come back in 3 months. And they weren't calling. And then I would tell my staff to call, and my staff would call and they wouldn't pick up the phone. So I took that over. I was like, and I control my schedule totally. I'm like, okay, you will come on this day. But that takes time. I've gotten faster at it, obviously. But I make them sit through all of that so that in that half hour, I am like done. Whereas usually I'd have all this other work to do at the end. Like I'm looking at the labs with them. And anyhow, I've just changed the way I do it, because otherwise you're right. At 9:30, they think their visit goes till 9:30, and you can't possibly be ready for the 9:30 patient at 9:30.
Correct.
So
That we find the same.
I appreciate that.
That's exactly how I do it. I review the labs, the previous labs, or whatever they have come before. I give them the prescriptions. I write my notes in front of them with them there. And I do say, you know, I'm maybe looking this way, but I'm just typing or whatever. So, but they're fine with it. They're fine with it. Actually, they're pretty patient about it. And I'm like, okay, let's do this. And have you done this? Have you done that? All the referrals that they want, I give them. I just send them. I said, I sent the referral already. You know, it's faxed, and I fill out the form for the lab for them to come back. You know, order the tests, whatever. Everything I do with them present, and the scheduling I have always done it myself, actually, because and that's it. That I learned like many years ago when I was with another doctor. It's actually by the time you send them to the front desk, sometimes they don't schedule. So they said, okay, it's busy, there's someone else there, and then I'm gonna call, and they leave. So even in the same visit when they're with me, I schedule them. So I'm becoming like really good about it, and it takes 1 minute, but can save me a lot of headaches afterwards, because I don't have to call the patient, how come you're not here? You know, we need to review your labs, you know, all that stuff. So I have learned to do it just there, and I have done it before, even before telemedicine.
Desiree, so when you have a patient, say you have a diabetic and you do a telemedicine visit, where do they have their labs done? Do they come to your office, or they go to a freestanding site?
I give them the option to come to the office, and we schedule them in different times. So they can come to the office and get the blood drawn here, or if they leave, they are in, you know, in Rockville, very far, or somewhere in Bel Air or whatever, then I send them a form for them to get the labs done. The majority of them before the visit, so I can review them with them when they're here, so that they have all that ready. And it's actually, some of them, I'll tell them, okay, go ahead and get your blood work. Let's schedule another telemedicine so I can just review your blood work. So it works out pretty well. Yeah, so I give them the option, whatever they prefer. Some of them are like, oh no, I'm afraid of LabCorp, or I'm afraid of something, and they don't want to go there. And then they say, I prefer to come to your office. That's fine.
Alice, is that what you're doing as well?
We're doing labs mostly. I mean, we mostly do them in our office, but what we did was early on we established this system where, you know, of like that they're being greeted downstairs and they go right to an exam room, and it's drawn in an exam room, and they leave without checking in and out. Like we made a big deal like on our website and stuff about like it's like low touch. You know, you'll just go right to an exam room, and we did this little goofy video of like showing us how like we tell them to wash their hands and we wash our hands. And what we've actually done that's really worked well is we have them come in for their labs and we do their vital signs during the lab visit. So when I see them for a televisit, I've got their blood pressure, I've got their weight. They've already taken their temp, obviously. So I find that with that info in the labs, I feel pretty comfortable not doing an exam on the vast majority of my patients. You know, I mean, unless they've got something obvious going on I need to see them for. The other thing I'm doing that I think has been great for me is I used to often like spend 5-10 minutes looking at the chart before I go in to see someone for a physical, right? I go back and look at everything that happened between last year and this year so I can remember, right? Now, the person, because they're always ready at 9 o'clock, I get on the televisit and I say, hey, I'm here, but I need about 5-10 minutes to look at your chart. I'll be back with you. I'll holler to you in about 10 minutes. Feel free to go do something else. I'll be back. And then that's during their visit, right? And so like they get it then that like I'm spending that time, because usually I kind of hid that from people. You know, I'd show up as though I knew what was going on, but like they had no idea I'd spent 10 minutes doing that. But now I like call it out. I'm like, oh, okay, I'll be working on your chart for 10 minutes. And they're like, okay, I'll be here. Got nowhere else to go, right? They're just at home. Anyhow, I found the psychology of it fascinating.
Yeah. So my excuse is, I'm getting organized here. Can you please bear with me? I'm getting organized. So those 5-10 minutes of, you know, pulling the chart, pulling the labs, looking at what emails I have sent, you know, all that. And I even talked it aloud. I said, okay, we were talking with, we sent some emails back and forth. Let me see what we said or something. Oh yeah, now I remember. So it become very interactive. But
yeah, I just say to them, I'm reviewing your chart. Like
exactly.
I'm looking at all that. Like, but they never really respond much when I say like, oh boy, we had so many emails back and forth in the last year. They don't ever take that well. They're always thinking. But I like to say to them like, hey, you've spent a lot of time like for free with me in the last year, by the way. But like they don't respond to that. So instead I just say, I need some time to look at your chart, and they're okay with that. But anyhow, I'm just finding it interesting.
Yeah, kind of nice. All right, so it's all right. Well, a very talky group. We're already 7 o'clock, almost 7, so 6:52, 55. Well, do you have anything else to say, Dr. Manuel?
Let me take. Oh no, it's interesting how, although we are working with different in different fields, so to speak, you know, individual practice versus a large group practice, we have very similar experiences. And I would say to what Alice experiences, is patients love to review with you their past visits, which helps to helps me to catch up, but it also feels as though they feel as though they're involved with their care. They have control. I'm not sure if it's the psyche, or it could be that they're so COVID fatigue, any attention is welcomed, even if it's just we're talking out loud. But I do think there will be a new, and a lot of people hate this word, but new normalcy in how we engage and interact with our patients. One of our, in OBGYN, our biggest, the volume for vaginal discharge is probably 40 to 50% of our visits. And now with telemedicine and sending them to the lab with the urine, it has become the least office visit type that we're seeing. And where we can spend more time in those patients who really have issues. And I haven't gotten pushback from our patients. So I find my experience with you guys very similar, despite the fact we're in different, we see patients in very different venue.
Do you see yourself telling the patient, get your own vaginal cultures?
Actually, most things can be done through a urine, but I do think in the future, as more and more women become leaders in medicine, I think we will be able to do not just vaginal smears, but pap smears, cervical cancer screening from home. I think it's coming.
Wow, that'll be interesting.
We can do an HPV right now from self-swab, but it hasn't caught on in OBGYN yet, but it's available.
Mm. So the way it is just the woman introduces it in the...
Yeah, I would say to you, Kaiser, California Northern California is the only medical practice out of the 8 of us that do primary HPV as their first step in screening for cervical cancer. Okay, that test can be done, can be a self-swab. And if that is abnormal, then it reflexes to a cytology from the same specimen. The thing about that, why we haven't completely adopted it, is because it creates more office visits. And as a prepaid medical group in general, more office visits does not mean more money for us. It means actually more weight on the system. So we're a one-stop shop. You get everything at one visit because we don't need a permission to refer. If I decide a patient needs to see an endocrinologist, she gets her referral that day. The primary HPV screening creates more colposcopies without answering the same question, does it prevent more cancer or death from cancer? And the answer is no. So the other medical groups besides Northern California, we're resisting and pushing back. But I believe the country will move towards primary HPV screening because women can do it in the privacy of their own home rather than coming into the doctor's office and having a speculum exam.
Well, there you go. We're looking forward for that.
I'm sure
Heard it here.
That is not something I thought we were touching on tonight.
Well, thank you very much all to participate. Do you have anything else to say? If not, then we can just say leave the meeting.
All right. Nice to talk to you guys.
Thank you.
Thank you.
Thank you.
Guys,
Bye-bye.
enjoy.
Bye.